We are up to our third thematic session of the day. It's called Health and Heat, Global Heat, of course, and it's being moderated by Elise van Belle. Elise van Belle, who works at Because Health, Memisa, Belgium. Elise, can you hear me?
So my name is Elise, as Annabelle said, and I am the General Director of the Belgian medical NGO Memisa, and I'm also the chair of the steering committee of Because Health. So this session is on the subject of heat, global heat and health. Population exposure to heat is increasing due to climate change, and we know that this trend will continue. So globally, extreme temperature events are observed to be increasing in their frequency, duration, magnitude, and exposure to excessive heat has wide-ranging impacts for all humans, and also is often amplifying existing conditions and resulting in premature death and disability. We have three speakers who will now present their case to illustrate the subject. The first speaker is Claire de Maury, who is a scientific collaborator at Cienzano in Belgium, and she will share her findings on short-term exposure to temperature and mortality from a risk and health impact assessment in 9 Belgian cities. The floor is yours, Claire.
Bonjour à tous.
Good morning. And thank you for giving me the opportunity to present the result of this study. I'm Claire Dumoury. I'm an epidemiologist at Cienzano, and I'm going to talk about the link between mortality and temperature in Belgium. This is, in fact, a work carried out by Risk and Health Impact Assessment Department. Well, to start with, what is Cienzano? Cienzano is the Belgian Institute for Health, created in April 2018. The most important mission is to support the policy at national and international level, and we also support healthcare professionals and governmental agencies through our activities and advice. And our role is also to give to citizens reliable data. This is scientific expertise in the field of human and animal health. And therefore, we have a certain expertise in different areas, in different research areas. We have 6 major fields or areas of action. For instance, some, because of the COVID crisis, are very active at present time, but I'm going to talk about health and environment today. And the subject is short-term exposure to temperature and mortality in Belgium. The goal of the study was to describe the temperature mortality relationships in Belgium and also to identify the most vulnerable populations. And we looked at the biggest Belgian cities and also their suburbs. It is half the Belgian population, basically. And the period is ranging from 2010 till 2015. In total, we registered more than 300,000 deaths in these cities and their suburbs. And we looked if there was a link with temperatures. A few words on the data we used. We used a lot of big administrative databases. We had a legal identifier. This is our national security number in Belgium, or so-called national register number. And we also related to the Meteorological Institute of Belgium, and we could obtain the daily temperature of the place of residence of each inhabitant. Of course, we didn't obtain this by name. In fact, as you can see on the right hand side, we worked with anonymized information. Now, these are the most important results of this study. You see it on the graph. This is the mortality risk based on the daily maximum temperature for the people living in the cities I have shown you beforewards. And you see a clear increase in mortality risk with higher temperatures. And to give you an idea, when the temperature, the daily maximum temperature reaches 31.3 degrees Celsius, the mortality risk is also increasing by 33%. compared to a day where the daily maximum temperature would only be of 21 degrees Celsius. 21 degrees Celsius, this is the value for which we found the lowest mortality in Belgium. And, well, to have a better overview of the situation, we have also analyzed different population subgroups. So we have had also a gender approach, and in women, the death risk was higher than in men. Risk was increasing by 40% for women and only increasing with 33% by men, in men. We also looked at the age, and we also noticed differences. For instance, people older than 85 years, there has an increase by 34%, but in the youngest groups, for instance, from 65 till 74, the risk was increased by 17%. We also analyzed the inhabitants living in the suburbs compared to the inhabitants living in cities. And we saw that those who lived in cities had a higher risk, 41% higher in highly urbanized areas compared to less urbanized areas. It's also related to the density of the population, and also in fact the presence of a lot of concrete and so on and so forth. And we know that in city centers it tends to be warmer over day and also warmer overnight than in a greener area. And then a last element, but I still don't have the results. This will be looked at if there is a risk difference in people with chronic pre-existing conditions, for instance, those suffering from COPD, from diabetes, or some having had a stroke or cardiovascular diseases, for instance. Just as a conclusion, in this study, we saw a clear age effect on mortality, even in Belgium, where we have a maritime temperate climate. But this increase in mortality is not only taking place during heat waves, not only, I repeat, during heat waves. We have also seen different of risks according to the groups. Some groups are more vulnerable than others. These results were observed for the past, so from 2010 to 2015. The past 6 years have been the warmest years ever recorded, and if we believe that the temperatures will become even higher, then we have to ask ourselves what will be the consequences on mortality, and what about, for instance, subgroups. And you have seen that some subgroups were more vulnerable than others, even for a small country as Belgium. Thank you very much for your attention indeed. Yeah, thank you very much, Claire. This very interesting
On va demander à tout le monde de bien noter les questions. Everybody,
information.
Please, note your questions in the Q&A, and after the three speakers, we will have a round of questions from the audience. The second speaker is Jeffrey Quarcy, who works at the Community Health Service of Rotterdam Rijnmond in the Netherlands, and who will now talk about the impact of climate change on health in the Netherlands. The floor is yours, Jeffrey.
Okay, so thank you. My name is Jeffrey Quarcy. I'll speak about the impact of climate change on the health of the Netherlands. I'm a medical resident in environmental medicine. So it's a table of content. We'll look at the effects. I'll also have a case study, and I have some recommendations. So first of all, when I was reading into the Lancet countdown, you see that they mention climate change as the biggest threat to human health of the 21st century. And they mention extreme drought, food insecurity, hunger, conflict, mass migration, etc. Very strong effects. But I was wondering, like, how is this actually in the Netherlands? Because I don't think this is so relevant. So with a group of other public health doctors, we decided to look into this and publish a review in the Dutch Journal of Medicine last month. And we come to 5 main health effects of climate change in the Netherlands, and I'd like to pass them one by one. So first, heat. Average temperature per year has steadily increased. Also, the Netherlands warms twice as fast as the world average. We see that, for example, the ice days will decrease, and that the last 30 years have been the warmest period in the history of the Netherlands. We have more tropical nights, we have higher water temperature. So this all shows that there's a heat increase in the Netherlands. Question for you guys: what is the 3 worst natural disasters in the Netherlands of the last 50 years? So that's it from the 1970s. It will be 2003, 2006, 2019, because of the heat. The heat waves have always caused a lot of mortality, high mortality. For example, 650 in the last one, because of exacerbation of nephrological disorders, aggravation of cardiovascular disease, heat stress, heat stroke. And not only mortality, also like morbidity. Because of sleep disturbance, we see like reduced labor productivity, also more accidents at work, so more people calling in sick. More heat also gives more social unrest, like increase of psychological complaints, see more suicides, more psychiatric hospital admissions. And this year it was found in the Nature Climate Change, the journal, that 31% of the heat of the last 30 years of the mortality can be attributed to climate change, which amounts to 250 persons per year in the Netherlands. So even without climate change, there will also be heat, but 30% of it is caused by climate change. And Netherlands is especially at risk because, as was already mentioned in the last talk, the elderly are at risk, and the Netherlands is a country with a lot of old people, and also a lot of urban people, a lot of obese people, and lonely people. Loneliness is a very important risk factor. And the urban heat island effect is strong. The urban heat island effect is caused by darker surfaces in the city that can be found. Also, surfaces that absorb more warmth. Also, because more heat is produced by more industry and more electric devices, and also because there's less wind between so the heat also stays in. So that's the urban heat island effect, and it's very strong in the Netherlands, which is one of the most densely populated countries in the world. Here you see a map of risk of heat and loneliness. You see here that it's quite high. It's in Dutch, but it means a lot of 75. This is like neighborhoods with a lot of 75 plus people, and who also experience a lot of heat stress and are very lonely. This is important because elderly don't have thirst signal so strong, so they don't feel that they are thirsty, which makes them become dehydrated a lot, and especially if they're by themselves. Also, somebody who cares for them is not always there. For example, they sleep under a very thick, for example, a thick sheet, which also contributes to the heat stress. So loneliness and not having the social interaction is very important. Here you see another sign of the urban heat effect. There's less green, for example, in Rotterdam, and less trees, which is not only the aesthetic effect, but also has an effect on the on heat. Less shadow and also less absorption. Absorption. Well, you would also see milder winters because of climate change, and it's suspected that it would also give lower morbidity. So this is actually a positive sign of climate change because of less accidents and less risk of winter smog. But this has not yet been observed in the Netherlands, even though it would be plausible. This is something that more research is needed for. Allergies, that's number 2. We see a prolonged pollen season, so the pollen season starts earlier, which means that the warmer season. And also we have pollen that are more intense because they're more, the new kinds of pollens have arrived from the south of Europe, like ambrosia. And already 20% of the country sensibilized of the population for these new exogene pollens. What does that give? Allergic rhinitis, sleep disturbance, concentration problems, poorer daily functionings, more people calling sick, a lot of medication use. For example, 1.3 million antihistaminics have been prescribed in the summer, and also a lot of GP consultations because of allergy. So significant morbidity. Then number 3, air pollution related diseases. Long-term air pollution, as we know, increases the risk of hypertension, coronary atherosclerosis, and diabetes mellitus type 2. Mortality in the Netherlands in 2018, particulate matters, 9,900 people died, nitrogen oxygen 1,600, and ozone 410. Especially ozone is important because actually the air pollution has been decreasing since decades in the Netherlands because of more strict emission rules, but ozone hasn't, and climate change is especially important for us ozone, which also gives aggravation of cardiovascular disease. So climate change and ozone gives an increase of ozone, and which is related to ozone smog. Number 4, infectious diseases. There are much more tick bites, and as a consequence also more erythema migrans, which has increased 5-fold since 1994. And there's a multifactorial etiology. It's also because we behave differently. We go more out in the nature, and there's more early detection, but still climate change also plays a role in increase of infectious diseases, especially also for the exotic mosquitoes who are on the rise. Aedes albopictus, which is a carrier of dengue and chikungunya. Culex pipens is also spotted in Utrecht, which carries the West Nile virus. And this also depends on availability of water. And we see more frequent and more intense precipitation, warmer weather, for also increased water temperature. And not even unexpected, there's already a deterioration of quality of surface water. For example, we see more blue-green algae in lakes, which causes toxins, which can poison people. More bacteria, like Vibrio, like Legionella, and noroviruses. Then also more insect plagues since 1990s, like the oak processionary caterpillar, which sits on oaks and causes allergic reactions or pseudo-allergic reactions like intense itch, urticaria, exanthema, respiratory and ocular irritation. And there are also two others, insects that are on the rise, Taponema nigerimum and Vespa velatuna, which is a wasp, which gives more painful, less poisonous, but more painful stings than the Dutch wasp. Finally, we have ultraviolet related diseases, because there are more sun hours and also more radiation, which we see more skin cancer, which has 5-folded at least since, and also the prevalence of cataract also increased 3-fold. At the same time, more vitamin D also is more sun also gives more vitamin D, which is actually a good thing because it decreases the risk of several cancers like colon cancer, breast cancer, etc. But we don't actually see a decrease in those cancers, so it might contribute, but it doesn't show any statistics. Finally, part 2, a case study. I want to show what we can do to prevent it. I'm going to read it. What can a doctor do? This is the ideal. This would be the ideal version. So a GP in the inner city receives a warning about an impending heat wave with code orange from the public health services. That would be us. The doctor learns about the importance of preventive advice and to be extra alert for early warning signs in vulnerable patients. The next day, a 71-year-old woman comes to the GP because of a skin rash. She has obesity, hypertension, diabetes mellitus, heart failure, and chronic kidney damage, for which she takes medication. She lives alone in a social rented house. When questioned, it turns out that her home is uncomfortably hot. She feels dizzy and has a headache. In consultation with the pharmacist, the general practitioner decides to temporarily discontinue furosemide, which is like a diureticum, with which you would lose liquid during the heat week, in combination with daily self-weighing the patient at home. The GP advises the patient to eat enough and also to control blood sugar and drink 5 glasses of water daily. The doctor also advises to stay in touch extra with the most important people in the social circle to check upon her, and also to find and look for cooler places outside of her home, such as the library or shady spots along the water. And the GP finally also refers the patient to the environmental health department for more extensive preventive heat advice, and also look at structural measures such as roof insulation, also greening the garden. So having less tiles and less stone around your house also decreases heat. So these are things that we could do as doctors or as medical professionals. Finally, we can see that the climate change is not just a future risk in the Netherlands, but actually a current burden for the last decades already, and associated with significant morbidity and mortality. Limitations, we've seen many qualitative effects, but the numbers are not always there when we see rises. And also the future, of course, depends on how we deal with it, with the climate mitigation and adaptation. So our article finishes with 3 recommendations, or at least on 3 levels. A medical doctor in a consultation room, that is For example, we as doctors, we could advise to have to give advice on safe sunbathing, on also we could look at describing less medicines, because medicines are actually 7% of the CO2 emission in the Netherlands, or the healthcare sector in general. Also look at prevention to stop smoking. For example, tobacco is responsible for 4% of global deforestation. So it has a big impact. It's like a win-win situation to make for health and also for the environment. Also plead for a more plant-based diet, which increases health and also diminishes climate change impact. Then we can also look at the health sector. So we are the medical doctors are the most influential figures in the health sector, and we could also look at, we have a lot of food spillage that we could go against. We can look at the medicines production, and we also can look at how can we reuse or how can we make our waste diminished. For example, there's a lot of plastics that's used. And finally, we also have a big say in the society. We can make sure that the health aspects of climate change are also mentioned in climate policies, because this neutralizes or makes climate change less politically divisive, because health touches everybody, left or right, progressives or conservatives. And this is also a voice that we can give in society. So this is what we advise. Thank you so much, and looking forward to questions.
Thank you, Jeffrey. Thank you. You talked not only about heat, but also about other elements impacting our health related to climate change. Adding on, for example, to what Steven van den Bosche said this morning on all the infectious diseases. So we go to our third speaker, which is Fiona Scorgie, who is a medical anthropologist at the University of the Witwatersrand in South Africa, and she will share her findings from a qualitative analysis on the experience of heat stress among pregnant and postpartum women and their neonates in Burkina Faso and Kenya. Fiona, the floor is yours.
Good day, everybody, and greetings from South Africa. I'm presenting today on the topic of maternal and neonatal health in Sub-Saharan Africa and the impact of heat. And I'm going to start off with a slide that is probably quite familiar to many people in the audience, as it shows quite graphically, I think, how the world is getting warmer. The graph depicts the annual mean land and ocean temperature and whether it goes above or below the average for that time period from 1850 to around 2000. And you can see quite clearly that from about the 1950s, that the temperature has risen above the average, and that increase is quite a steady climb upwards. What does this mean in Africa? Well, we are already experiencing and will continue to experience in the coming years extreme weather, high temperatures, more frequent heat waves, intense rainfall, disasters, and changing seasonality. And you can see from the graphic on the right-hand side that the continent is expected to be hotter by, on average, 6 degrees compared to the 1980s by the end of this century, which will render parts of the continent completely unlivable for humans and animals. What does this mean for maternal and neonatal health in Africa? Well, there's actually very limited evidence on this population group. And this is one of the reasons why the group that I'm part of, called CHUMNA, decided to look at this more carefully. This is a graphic that we developed at the start of our study, which really tries to depict a way of thinking about how extreme heat and other extreme weather events could impact on maternal and newborn health. And the most obvious effect really is through direct physical effects. And I'll say a little bit about that in a moment. But this also includes mental health outcomes like stress, anxiety, and depression. But we should not forget that there are also indirect pathways of causality and that, or of impact rather, which relate to disruption of health services and failed crops and malnutrition, which in turn impact on the nutritional status of pregnant women, of nursing mothers, and of growing neonates. All of this takes place, obviously, against a broader social and economic context, which we need to remember. So just to say a little bit more about those specific physical effects, the direct physical effects of extreme heat on maternal and neonatal health. The literature does show that, that high temperatures increase risk of preterm birth, congenital abnormalities, malaria, bacterial infections, and hypertension, which is associated with preeclampsia. But there are also occupational health risks, which are quite easy to overlook. It's important to remember that pregnant women are likely to continue to be physically active throughout their pregnancies in Africa. Many of them continue to work in agricultural settings as workers and also continue to do household chores, which are often very, very onerous, involving carrying water or firewood for long distances in the searing heat. So there's obviously a great risk here for dehydration. We also need to remember that healthcare workers are likely to be more irritable in the heat and less likely to be able to offer care to the patients that come to see them during the heat, periods of heat. So the remainder of the presentation is going to focus on the qualitative research that we did in Kenya and Burkina Faso. And really what we were trying to do here is to understand how heat stress in pregnancy, postpartum, and neonatal periods is experienced and how it's perceived in these countries. Very often we focus, for good reason, we focus on the statistics, on the medical and epidemiological data, the numbers behind climate change impacts, but we don't really, I think, give enough space for people to talk about how this is affecting them in their daily lives. So those voices are important to capture as well. And we looked at how this impacts on women and neonates on 3 levels, at the household level with others in their household, also at the health system level and more broadly at the community level. And this framework impacted on how who we chose to speak to in our research. So just a word about our methods. They were qualitative. We did a series of focus group discussions, individual in-depth interviews, and key informant interviews with a range of different groups. I won't mention them all, but they're listed in the slide. Those numbers in brackets are the sample sizes for both sites combined, Kenya and Burkina Faso. And we then synthesized this data and presented it in a series of workshops in the study sites to community members, but also to key stakeholders in policy and programming. They gave us feedback on the data and on our interpretation of the data, and then we sat together and tried to work out how we could develop interventions to address these problems in these settings. So just a word on the study sites. As you know, Burkina Faso is on the edge of the Sahel in West Africa. We worked in an urban site and a rural site in the country. And then in Kenya, on the east coast, we worked in the sub-county of Kilifi, which is right in the east, in the south of the country on the coast. Just take a note of the average temperatures there in the hottest seasons. And just to mention that in Kenya, the extreme humidity often makes the temperature feel much hotter than it actually is. These were the conditions in which we collected the data. The rainy season was extended in Burkina Faso in the year that we collected, which was last year, we collected the data. Some villages were inaccessible during the rainy season, so there was interruption and delay in our data collection. In Kenya, most of the focus group discussions were held outside under trees in the shade, but even still in the shade, many of the participants were very drowsy, and in fact, some of them fell asleep during the interviews. They simply couldn't stay awake because of the heat. It was quite unbearable. Okay, so what did we find? First of all, just to focus on effects during pregnancy. Women spoke about extreme exhaustion and interrupted sleep and how difficult it was to get enough rest. They spoke about dehydration and the fact that everyday tasks became more difficult to perform in the heat, which impacted on their productivity and even on their earnings. There were mental health consequences, anxiety, restlessness, and social isolation, and the latter particularly in Burkina Faso. Interestingly, in Burkina Faso, pregnant women are discouraged from certain behaviors that other household members may engage in, which would help to cool them down, such as sleeping outside at night, removing some of their clothes to be cool, or even refreshing themselves with having a bath late at night. And they were discouraged from doing these things because they were pregnant. Just some voices from the participants themselves. This is a postpartum woman in Ouagadougou in Burkina Faso who spoke about how she felt uncomfortable at all times, how women would experience a heat rash on their body, insomnia, feel strange movements of the fetus. Male partners in Kenya observed how mothers got really exhausted and dehydrated and would experience these hot temperatures, especially from overworking, which made us wonder to what extent men themselves were doing something to assist women with that work. We were interested to know as well how the heat was considered or conceptualized to harm the fetus and the newborn. How do people understand that harm to play itself out in newborn babies? They described how a newborn baby would cry a lot in the hot weather, would not want to suckle, and that would impact on breastfeeding, nutrition, and dehydration. Some would even have respiratory problems in the heat. In Burkina Faso, the baby in the womb was considered to heat up, and this would trigger preterm birth. And it would also impact on their development and how they appeared when they were born, that some would actually be out of shape or they would look like a sick person when born. In Kenya, community health workers spoke about babies being born in the heat as being underweight and having blisters in the mouth, which would impact, of course, with impact on breastfeeding and sleeping. There was mention of some beliefs in Kenya around the need to limit water intake during pregnancy, lest this too much water harm the fetus. Okay, and in terms of delivery and postpartum, women were said to experience a double pain, in a sense, the pain of childbirth and then this extreme discomfort of the heat. Kangaroo care was considered a challenge. It's the keeping of the baby on the chest of the mother because it was too much perspiration. It was simply too uncomfortable to have another body against your own skin. And there were some cultural practices postpartum in Burkina Faso in which mothers and their babies were expected to remain at least 7 days inside in the stifling heat. Finally, what could we say about the health sector? Was there resilience to heat in the health sector? We found that really there were a number of health system weaknesses in these both countries, and this intersected with the problems of heat. And overall, the facilities were actually not well prepared at all for heat extremes. Many of them had poor ventilation, no water was available. Patients had to bring their own water to the facility for childbirth. There were no cooling rooms set aside, as might happen in other settings, for people to sit in at least even for a few hours just to cool down. There was very little outdoor shading, and facilities would get very crowded, which would force people to try to sit outside, but then very little shading was available for them. Women's antenatal and postnatal appointments were sometimes cancelled because women could not afford the transport to get to hospitals and clinics, and then they would have to walk in the extreme heat, and obviously that was something to be avoided. And that at hottest times of the day, facilities would sometimes be emptied out because patients would not want to come to the facility. There was some indication that women might actually change their choice around where to give birth and decide to give birth at home if it was too difficult to get to the hospital in the heat. And then some indication as well that interventions like malaria prevention might have been impacted by the heat because people would consider the mosquito net to actually trap the heat while they were sleeping, and they would just pack them away instead. Where do we go from here? I just have a couple more slides on this. We need to start thinking about interventions. We need to do more than just document the impact of heat. We need to think about how to address it. And so my colleagues and I have developed this grid really just to summarize potential interventions for this population. And you could divide them broadly into behavior change and health promotion. Secondly, interventions that target the health systems. And thirdly, those that focus on the built and natural environment. And if I can just give one quick example on that third level, the graphic just shows how there are a number of simple, low-cost cooling interventions and building modifications that can make a huge difference. The graphic on the right shows that if you can paint roofs and walls with reflective white paint, have more shading, green shading outdoors around the facility, as well as the use of electric fans where electricity is available, and the spraying of water mist. And then that woman standing next to the pregnant woman is a midwife or community health worker who can be trained to monitor the pregnant woman for signs of heat stress and dehydration. So these small, quite small, relatively low-cost interventions can really make a difference. Just to conclude, there's compelling epidemiological evidence that action is required. There are some quite serious consequences for pregnant women and for neonates. The data that I've presented today is the anthropological data, which shows how extreme heat compromises the health, well-being, and quality of life of pregnant and postpartum women and neonates in these two settings. And there is some evidence that heat impacts on the delivery of health services, but this is really an area that requires further research. How to act, though, is complicated. There's generally low awareness of the impact of heat on mothers and their newborns, and of how dangerous this can be. It's not clear really which interventions that have been developed for other populations may be adapted specifically to the needs of pregnant women and newborns. And finally, in national adaptation plans for climate change, in many parts of Africa, in fact, maternal and neonatal health is not addressed. It's not included at all. And that really needs to change. So just to acknowledge and thank my colleagues on the Chumna project and the funder for the study, which is the Belmont Forum. Thank you.
Thank you so much, Fiona. Very nice illustration of your findings. So we have 15 minutes left for questions, and I already received some, so I think we go straight to the questions. The first question is for Claire.
Do you have also checked the mental health, or have you seen anything? Yes, thank you very much for this question. Indeed, as regards the risk of violence, we don't have data as far as this issue is concerned. For mental health, it's quite different and it's quite difficult, to measure. We are working on studies with not a lot of individual data. We work with a huge cohort of people, but not an individualized cohort of people. And we would like to look at the medicine consumption of people. We have data there, and maybe we will come to some conclusion. For instance, people taking more tablets, more medicines, we will see if they have a higher mortality risk than others. And then for the low income countries, in the study, we have only data on people living in Belgium. What would be interesting? Maybe there can be some differences between people from other countries. That would be interesting to look at. But once again, we don't have the necessary data. But that would be very interesting indeed. You're right. Yes, maybe I can add a comment. I was surprised because the difference in mortality between 21 degrees Celsius and 31 degrees Celsius, the difference is big, but not that big between the oldest group and the youngest group, because I think that the oldest group, they have already another comorbidity. There is also a risk of hydration. And I would like to know for the youngest group, but the 65 plus, why are they dying? Yes, in the youngest group, the 65 plus, globally speaking, they have less cardiovascular diseases. Cardiovascular diseases are more common in older groups. So they are dying for different reasons. For instance, cancer. Yes, we have a lot of cancer in this age
so
group.
I go
okay, thank you very much.
Jeffrey with a question from, I think from Xavier. What are the new priorities for epidemiological surveillance based on the Netherlands experience? And how would that translate in more tropical settings? Speaker, Jeffrey.
Yeah, ok. Juste pour ajouter, hein, concernant la santé mentale, aux Pays-Bas, on voit bien qu'il y a une hausse de suicide et aussi de maladies ou de mentales. Donc, ça, c'est peut-être. Et vu que Belgique et Pays-Bas, on a des voisins, peut-être ça, c'est aussi le cas pour la Belgique. Mais vu qu'il y a un manque de données, je voulais juste ajouter ça. Just, so what are the new priorities? Yeah, so concerning heat, right? I believe because I mentioned 5 effects, but for heat, I would say loneliness, psychiatric diseases, and also chronic diseases, because they're also aggravated. And if we look on also to the other effects, hay fever and Lyme disease, I think these are the, together with skin cancers, would be my list of priorities. How would that translate in more tropical settings? I think especially in tropical settings, chronic diseases would be a main point to focus on because of the double burden now. Loneliness, I think it would be less of a problem, and Lyme disease is also less common, at least in tropical countries. But I think chronic diseases are very important to increase the resilience to heat waves. Yes.
Okay, thank you. There's a question from Etna Juga, and I'm not sure who it's addressed to. So you can all see if you want to respond. In the last months, we have observed a political conflict that will influence the gas supply in Europe. In a situation of scarcity, what provisions are you planning to take at the level of health units in terms of heating of infrastructures and all the elements that depend on this component without impacting on the quality of services? Anyone feels eager to pick on that question? Jeffrey?
No, not so much.
So, what provisions are you planning to take at the level of health units in terms of heating of infrastructures and all the elements that depend on this component without impacting on the quality of services?
I find it a hard question.
Yes.
Because I don't understand what is meant with the heating of infrastructures.
I do agree. I've read it twice and I'm still not sure what exactly is asked. If the person wants to clarify the question, the chat is still open. Any other questions from the audience can be put now. I'm just checking. No more questions. So maybe.
I also have one small question maybe for Demory. Because like the ideal, the heat, with the least morbidity or least mortality would be 21 degrees in Belgium, right? I know that in Holland we found an optimum of 17 degrees, with below it and beneath it already more degrees. How did you get to this degree? I was just wondering.
Ce qu'on a utilisé,
What did we use? We looked at mortality with a lag of 7 days before death occurred. Maybe this is the result of differences in the modelization. Maybe we can find there some little differences. What is important is to be able to quantify it and to use, of course, the same statistical model. Do you think that this tool could be used at global level? Could you use this tool, for instance, in tropical countries, or is it more a local tool? Well, it's I would like to say it's more specific. In Europe, we have more or less similar values, but it is not something you can broaden up to other countries where you have a different climate. No, we have differences there with other countries.
Thank you. So if any of the other panelists want to ask questions, you can, of course. Otherwise, I have another question to Claire. Merci pour l'étude sur l'association entre la température.
Thank you very much for your study related to temperature and death in Belgium. Have you looked also at other possible factors? Yes. What's interesting in the model I used, the people are their own, how can I say, we don't use as confounding factor the age or the socio-economic factor. We don't need to introduce that in the model. It's taken immediately into account, but nevertheless, in the model I used, we needed to integrate things that might change, for instance, temperature. And this is the reason why we used as a confounding factor air pollution. We had, for instance, data related to the ozone layer. We integrated this in the model, but this hadn't a major impact on results.
From Marlies to Fiona. Thank you, Fiona, for this interesting study. Would you have an idea if there is more evidence also from other countries as to the impact of heat on women's decision to deliver at home?
Thank you for the question. I'm actually not aware of any other studies that have looked at this. We certainly weren't expecting to find it, so it was a little bit of a surprise. But I think that it would really depend, if I can just comment more on the settings that we worked in at least, it would really depend on the type of settlement that you're talking about. So we found this effect in Kenya, and we were working in rural areas where the households were very far apart, and often the distance to the birthing facility was very far. So these were the poorer families who could not afford the motorbike taxi, for example, to take them to the hospital to give birth, and would make the choice that, in this kind of heat, it's just not feasible to sit in a really, quite stifling, poorly ventilated health facility where there's no water. And whereas at home, they might have more control over their situation in the heat, at least. So I also we didn't look at the prevalence of this, we can't put numbers to it. So we really don't know how big of a shift this is. And I think that also the thing to mention is that in Kenya, there was a higher percentage of women who were choosing to give birth at home anyway. That was the sort of pattern in place than in Burkina Faso, where the percentage of facility-based deliveries was much, much higher. So perhaps in a place where there's already a tendency for women to, where that choice is maybe more culturally acceptable to make, it might be easier for people to say, yeah, in the heat, I'm going to just stay at home and give birth, yeah. But it certainly is an issue, a question that we do need to explore further. Yeah.
Thank you, Fiona. So do you have any idea if heat is an element that is anyhow impacting the risk of preterm birth, as you said, congenital abnormalities? Because you could say that in equatorial regions, it's always much hotter and much warmer than in our regions in Europe or Northern Europe. Do you have any idea on that, if it is an element that is anyway increasing the risk?
Well, so the evidence that I mentioned during my presentation on congenital abnormalities in preterm birth and those kinds of physical effects really comes from a systematic review that members of the group that I'm part of, they've completed this. It was published in the British Medical Journal last year. I can put in the chat the reference if people are interested to look at it. But and they did, they've also been looking at using time series analyses over a period of time and have found that this rate has increased. It's difficult to say for sure whether this is, there could be other factors influencing this, but it's unlikely to be the case. There is the increase in preterm births over the last 50 years is matched by the increase in temperature, and it follows the graph very closely. So I think we can be quite certain that this is, in fact, as we're having more days over 38 degrees or whatever, more frequent and of longer duration heat waves, that we're going to be seeing this effect more and more. Yeah.
Okay,
if that answers your question.
That's an answer. No, that's an answer to my question. That's very clear. Thank you very much. And I think we are coming to the end of this session. Thank you very much to the three speakers, Claire, Jeffrey, and Fiona. You can also find more information on who they are through the links in the program. So back to Annabelle. Thank you.
Elise van Belle, thank you very much for this moderation